Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Arizona Listen Up Hearing Center. I help patients to effectively treat their hearing loss so that they can connect better with their friends and family and remain independent. The reason I'm so passionate about helping patients is because I lost my brother Robbie twice. First to his hearing loss from radiation to his brain tumor, and again when he passed away. I only care for ears. I'm the E of ENT. I've performed over 10,000 ear surgeries and taken care of many more people with hearing loss over the past 20 years. I'm the founder of Listen Up Hearing Center. I'm the author of a book of the same name, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to listenuphearing.com. That's listenuphearing.com. Today, I'm excited. I have a great guest. It's Dr. Alice Cellino. She is an audiologist who received her undergraduate degree in business administration from Columbus State University and a clinical doctorate in audiology from Auburn. She did her externship in the United States Army at Fort Benning and at the Pediatric Ear, Nose, and Throat in Atlanta. And then she joined Columbus Speech and Hearing, where she is now the executive director. She's in charge of it. And it's an interesting clinic because it provides a broad range of services, including speech, hearing, balance, reading therapy, and occupational therapy. If you're not aware, there's very few places that do all of that under one roof. We're excited to talk to her today about that model of how she does that. Alice, thanks for coming on the podcast today.
Oh, thank you for having me.
So tell me a little bit about, your journey from, a budding student to an audiologist to the executive director of a center that provides comprehensive services.
Yeah. So I really grew up in the field. My mom is an old professor out of University of Tennessee, and then she actually taught communication disorder sciences at Auburn. And after her professor time, she was a go-getter. That's always been her move fast personality, and decided she wanted to open a private practice in Columbus, Georgia. And so she did, and that started as a one-person practice. I love the story. She and a psychologist literally rented one room that had one couch, and they had to alternate patients because there wasn't room for both of them at the same time. And she started that practice, and I grew up, my mother and I are incredibly close, and I grew up listening to the stories she would tell. Appropriate, not violating HIPAA type things, but I was really fascinated and inspired by one of my favorite stories. Was it was a physician in town who had a stroke, and she was very young. And mom would pick me up from school, and we would go to the physician's house in the evenings, and they would do therapy together. And just through some incredible intensive therapy, that physician completely regained all of her expressive and receptive communication skills. And I can remember watching that as a kid and thinking, holy cow, this is awesome. And so I grew up in the field, and then when decided that I really wanted to join the practice, that fit me well. And like a lot of audiologists, I thought I wanted to go into speech pathology, got into the field and decided, I really prefer the diagnostic setup of audiology. And so went that way. I love vestibular sciences. That's definitely my favorite. If I had to pick one discipline, that's what I love to do. But was able to join the practice, and mom, she is now retired at 80, but we can't keep her out of the office. She still comes in and does all kinds of just whatever she wants to do, pro bono therapy with folks all over town. And it's amazing. We have a really neat and unique setup of the being able to work as a family. Is not for everybody, but if it is for you, you can just love it. And so we enjoy that very much.
Well, so that's one of the unique things, obviously, is a multi-generational family, right? Are there other people from the family who work in there as well?
Yeah. So we've grown. We're a big practice now. In fact, fun fact, I've got 41 employees, and 38 are women, which we don't do on purpose, but that just shows you how the field, it's a predominantly female field. And we love that. We laugh and only teasingly tell the only drama comes from the three guys, never from us. And so but my husband was a banker for 25 years at a big bank. And then when the practice had grown so much that I could no longer see patients. I mean, we do everything in-house, everything. We do our own billing, we do our own accounting, we do all of it. I mean, I'm doing the quarterly tax returns. That was me. And that was where a business background really helped. But it got to where I couldn't see patients anymore. There was just not enough time in the day. And so thought about it hard and stole my husband from his, corporate life, which was a wonderful thing to do. And so now, not only do I work with my mom, I work with my husband. So we really have doubled down on the family aspect of it, but it's wonderful for us. It's great.
And so you're not a pure audiology practice, and you're not just a pure speech therapy practice, correct?
Correct. We have
or even two. So you do a bunch of stuff, reading therapy as well?
Yes, we do. Yep.
And so how did that evolve? I mean, I assume you have a predominantly pediatric bent, or is that just one of the areas that you?
I would tell you, yeah, I agree that I mean, when you really break down the demographics of our patients, speech therapy is the biggest portion of our practice. I've got 20 plus SLPs, and then I've got 5 or 6 audiologists, and then 2 occupational therapists. And in that pie chart, the pediatric population would certainly be the predominant patient in the speech population. But we definitely do all ages. In fact, we have a pretty heavy adult therapy speech population, which providers really love. I mean, the outpatient side of speech therapy can be hard to find. And so in the adult population. And so but pediatrics are our heaviest bend. And I think one of the things that makes us different is that we truly try to look at how can we solve the problem in front of us. And so we noticed in the early speech years that, golly, well, these kids with language disorders often have reading disorders. I mean, that's a receptive language disorder itself. Sure. And so that branched into, well, how can we help them? Let's talk about reading therapy. And then those kids that branched into occupational therapy, where, I mean, the fine motor skills and body language and just everything that contributed to a healthy child communicating effectively. We said, ooh, we need this. And so we would bring it in. Our next step is to bring in neuropsychology, because so many of our kids would really benefit from that. So the clinic grows really based on what we see as the need in the community, and we just kind of go for it.
And so occupational therapy as well. Can you explain what that is for the listeners so they kind of understand what that is?
Occupational therapy is the diagnostic and rehabilitative field for all ages where fine motor skills have been affected. So those can be really critical. So even sensory issues, the fine motor skills that go in with feeding, that's an occupational therapy division. The fine motor skills that go with buttoning or handwriting, or the ability to hold a fork to feed yourself independently. It's the fine motor as opposed to the gross motor that you typically see with physical therapy. And there's a lot of overlap. Our occupational therapists also are certified in vestibular rehab, and they're phenomenal. I mean, they're, for example, walking the hallways and doing habituation and substitution exercises for our patients with peripheral vestibulopathies. That falls under an OT category. So it's the finer side of physical therapy, if you kind of want to summarize it that way.
Well, how did this evolve? I mean, your mom started out as one practitioner. And so how did this all evolve? I mean, I'm not aware of, many freestanding. So, for the listeners, this is often, you might find all these departments at a academic medical center, not because of design, but just because they all happen to have all of these services. And so even in the academic medical center, they're typically not under one roof or one coordinated clinic. So, I think I don't know, but I'm not sure I know of another place. It doesn't mean they don't exist, but I suspect organizations like yours are few and far between. How did that evolve? Can you tell a little bit about that?
Yeah, I truly think it was, she loves what she does. And I definitely love what I do. But that led to it's so funny. I tell my young my young therapists, my young audiologists, or folks that are just coming up for private practice advice, if you'll just solve the problem in front of you, I promise the next opportunity will come. Whether that's an auditory rehabilitation group, which, you've got your hearing aid patients who say, I still can't hear. Somebody teach me how to do that. Yeah. Say yes and figure out how to solve that problem. Don't be afraid to make it financially viable. Don't be afraid to try something. And if it doesn't work, stop. It's okay. So I honestly think the clinic grew and has evolved. We lovingly call it the platypus. Exactly what you said there. It's just sort of this crazy blend of different things that aren't typically together, but it works great. And that just came from, here's a need. It really does fit into our skill set. Let's go do it. And that's how it happened.
And most of your patients, I assume, are utilizing more than one area. So, talk a little bit about that on the pediatric side, and then a little bit of that on the adult side.
So a great example, we have a Parkinson's group of patients with Parkinson's disease. And those patients typically fall into all three categories. Almost all Parkinson's patients fall into all three major categories that we serve here. The Parkinson's often affects speech, voice quality, voice strength. There's actually a very successful therapy called Lee Silverman voice therapy. That's the official name, that helps Parkinson's patients who can't regulate their voice well get that back. That's a critical thing for them. It's also a critical swallowing therapy for Parkinson's patients. That's often, as you obviously know, very effective. So we got the audiology side, we got the speech side of the voice therapy and the swallowing. Those patients are often older, and so they have hearing loss. And as we're really trying to maximize their full-on communication skills, we are there for the rehabilitation part of audiology. Also vestibularology. When those patients have affected balance, we get in and try to give a good picture of their current status and do fall prevention programs and look at ways to maximize stability. And then that's the audiology part. And then the occupational therapy part, the fine motor skills like handwriting are affected often. And so we get in and do a whole clinic approach when needed. Depending on, of course, what that patient presents, but that would be a good example of trying to really encompass that patient. And then, for example, our sweet kids who are on the spectrum, on the autism spectrum, when receptive and expressive communication are impacted, the speech side goes after that. Audiology makes sure that we can hear and that we don't have any kind of auditory issues that we need to address to make sure that speech is in the clear. And then occupational therapy. I'll tell you a story. We have a therapy dog. Our director of occupational therapy, her name is Caitlin Barfield, and she's amazing. And when she joined us a few years ago, she said, I have a therapy dog. Are you willing to try this? And I was really hesitant because, we've all been on the planes and seen the therapy animals that we were like, that is just somebody bringing a pet on a plane. And that was my first reaction, but I said, yep, let's try it. His name is Gus. He's a golden retriever. And I have seen particularly kids on the spectrum work with Gus and do things for Gus that they would never do with a patient. With a therapist. For example, combing Gus's beautiful ears, fine motor skills that go with that. One of my favorite memories is we had a kid who had some real sensory issues eating. And I think it was whipped cream. I think it was something, tactile that was kind of fluffy and just a different feel in your mouth. And Caitlin was able to get the child to go after that texture by putting whipped cream on 2 different plates, and Gus and the kid ate together, just, right there at the table. And so I think those type of services are underutilized, and they're hard to find, and there's a lot to it, but wow, it's really cool to see.
Yeah, I'd agree. They're really hard to find, and especially under one roof. Some of these people must be spending multiple hours at your clinic a week. Is that right?
Absolutely. Yeah.
Do get streamlined appointments by and large, or how does that all work?
We try. We really try, but I would tell you it's hard to come by. Yeah. Our waiting list right now, to my knowledge, and I could be speaking, I may not be correct about these details, but our town of Columbus, Georgia, which is a big town in Georgia. I think we're the third largest city in Georgia, but after Atlanta, everything's kind of small.
Sure.
The wait time to get in for therapy can be months. And I think we're the only practice accepting new referrals, if I'm not mistaken. And that's super frustrating. For patients, it's frustrating for us. This is a plug for anybody who wants to go into the communication disorder sciences. There are jobs waiting for you, begging you to come in. But with that, we tell our patients, listen, if an opening comes up on the OT schedule, take it. Don't wait for the same one at speech, and don't wait for this. Take what you can get, because that's the key to getting in.
Yeah, sure. Obviously, the population is definitely outstripping the growth of the professionals who are able to provide these services. I think that's unfortunately a trend everywhere.
Yeah.
And so, as I think about this model, probably one of the challenges I would think is collaboration between the different disciplines. That they're also busy. As you're describing, it sounds like your schedules are probably 110 to 120% full or something of that nature. So how do you manage that? Interaction between the professionals to coordinate all the care. That to me, besides the one-stop shopping concept where you're all under one, but to me, that's probably the real power of your organization. So how does that work on an interprofessional level?
Well, you nailed it. And I will tell you, I feel like administratively, that is probably my greatest weakness. We make our meeting time, and we definitely set collaboration time. Everything is always on schedule, and then we'll get a call. It never fails that one kid needs to be seen. There's an emergency. Had a pediatrician call this morning. It's like, can you work this kid in? And so we often end up sacrificing that time because there's just a patient need that comes up. Nonetheless, we still attempt it. Mom started this in 1977. Okay. And when we were growing and growing, and particularly when we were doing all of the inpatient hospital work, we had a couple of locations. And what we learned with that, even a couple of locations in the same city, almost around the same block, but that if you had to get in a car to go from A to B, you practically didn't see each other. And it was really an interesting phenomenon. And so in 2009, we built our mother office, which is, I'm pointing next door. It's next door to us. And that was great because we got to build in observation rooms for therapy. I got to sink the booths in concrete. And so we wheeled stretcher.
Go right into them. Yeah.
Yeah. It's fabulous. And then in a good way, we outgrew that building, and the building next door that I'm currently sitting in came available. And we said, okay, if we ever go back to two locations, it would have to be literal next door neighbors where we're walking 15 feet, not getting in a car. And that's what we were able to do. So now this building is our adult building. Right. And I think that's been helpful for, some of the populations that we have all together in a waiting room probably don't mix. They're great, but they don't mix well. You've got your older patients here for stroke rehab, and then you've got your 2-year-olds.
Crying kids at the same time.
Yeah. But collaboration. So I'm sorry, to answer your question, we try to grab each other in every moment that we can and really work through, if it's a clinical collaboration, those are easier than the meeting collaborations of what's our next step.
Well, I meant actually clinically. So do you do some of that electronically? We've all now gone from paper to electronic records by and large. I would think you are, given the size of your clinic. And so how do you it's just kind of an interesting thing. Like, how do you manage that electronically? It's one thing to generate the notes. It's another thing to interact about a problem. How does that work because you've got so many different disciplines?
Yeah.
I have my medical staff and my audiology staff, right? So there's really two disciplines. So the collaboration is a little easier, if that makes sense, right? Because you might have somebody that, by even your example, have four providers or 4 disciplines that are providing care.
Yeah. It's neat. I don't think anybody's ever asked me that before. I would tell you, we write perfect notes, and I mean, perfect tongue in cheek, but definitely with a recipe so that we read each other's, if it's a progress note, we read them to know, okay, this is what's happening next. And we're really good about useful documentation. And when I say that, we tell new providers, listen, I don't know what the TAPS is. I'm not exactly sure what that speech test is off the top of my head. If you tell me we've got a 20% on the TAPS and in this division, tell me what to do next in the note. And so I think we're really good about leaving useful instructions for each other. And I think that's also how we have developed a really great referral base by but when I've noticed when students get out of school, one of my favorite stories is that they'll say, oh, we've got, a conductive hearing loss at all these frequencies and type E temps. But then they'll send that back to somebody who's not an ENT who doesn't know what
to do with it, right?
Yeah, and they're like, ugh. And so we avoid that. Say, hey.
Yeah, I think, at least watching audiology, electronic health records have evolved audiology, unfortunately, away from the report, if that makes sense. So when I first started 25 years ago, in a lot of ways, audiology looked at the note as their work product, like this beautiful note with all the information. And I think the electronic side is kind of take it to the exact opposite, where it's like, well, here's an audiogram, type B SIMS, mild to moderate, downward sloping, sensorineural hearing loss. It's like, well, those are all true, but it doesn't actually tell the person on the outside what to do. It's kind of interesting. I think that is somewhere that electronic health records have kind of taken away that. We all suffer from that, right? We all get a 4-page report where you're just looking for the 2 sentences that actually tell you what you need to do.
Right. Absolutely.
So, and how about, do you have teaming and that type of thing, or does that happen kind of just spontaneously?
Just spontaneously. We do have that in our EMR system. In fact, during COVID, one of the things, my husband joined right before COVID, and the timing of that was so interesting, but he got in and did things in the EMR system and administratively that, quite frankly, I wouldn't have figured out. And so he had our system will send out secure Zoom immediately. And we were able, in those first days of COVID where nobody was in a building, we were able to continue therapy with all of our pediatric patients. We had them set up doing Zoom for speech, not for audiology, for virtual therapy with those patients. And so our system will do all the team stuff, but I don't know how to do it. We just grab each other in the hallway.
Fair enough, right? Sometimes it's too many tools. And how about collaboration? So, the other thing I think about is do you have problems? I guess you do more adults during the school day and then the kids are after school, or how does that work? Because that would seem to be one of the issues.
So certainly because so many kids that we see, I think our predominant population across all disciplines is the under 5-year-old child.
Preschool.
Preschool. So we see them all day long.
Oh, okay. Yeah. And then I assume then the school age ones you see probably in the afternoon after or something like that. That's interesting. I hadn't really thought about it, but that is one of the issues, obviously, is therapy outside of school. Well, I assume some of them transition to therapy within the school context.
Right. Correct. Yeah.
And so I assume that, again, it's the note that collaborates with the educators and all of that. So, well, where do you see it going from here? So, all right, so you've got this platypus or octopus or whatever you want to call it. Are you just going to optimize, or do you continue to grow, or where do you see this going?
I think I would love to see us bring in neuropsychology. I think my town is missing, I think, the in-house resource where you've got a kid who is up to date with speech and language development. We're okay with fine motor skills, and we're still struggling. And so right now you can get neuropsych services in Columbus, but it's hard. Everybody is totally maxed out. So I would love to see that come in. I think we could add that collaboration, particularly to our early language kids, and really make a difference. If we knew what the executive functioning levels were of these kids, what their strengths were, you could really make a difference in therapy. that would be a fabulous tool to have. And so I think that's a great need in the community. And our friends in the community that are not with us are doing a great job. They're just overbooked. And so I think we need to see if there's space to bring that in.
So that's another tab on the website, it looks like.
I hope so.
And are you going to stay single location? Is that the goal?
Yeah, I really want to. So I was on a really cool thing, and actually you really need to know about this. I was on a development team for a boothless audiometer during COVID, and the development part, it had to meet the Veterans Benefits Association specifications, which are pages written in federal law about how you test hearing for a benefit. And so it was a product out of South Africa. I got to modify it to meet American needs. But all that, I would be fully confident in giving you pre and post-op audiometric data from the boothless audiometer and having no concern whatsoever that you're getting, exactly correct data up from the audiometer outside of a booth, which means you can now set up small satellite clinics really easily. Without
the space. Yeah. Audiology takes up the most space in my clinic.
Absolutely. In fact, in this new building, I did bring in 2 of our baby booths, but the other 2 rooms are boothless, and it's going well. So I guess we could always branch out with satellites, but I really like being together, and I may not want to this may be as big as we feel like we can do a good job with, and that may be where we stay.
Yeah. Some of our hearing and noise testing requires larger booths. So that's one of the things. So we have all large booths, and so the footprint is pretty large. We have 3, and they take up, when you really look at the space consumption, it's substantial. So well, this is wonderful. And so tell me about, I ask everybody this: what's your favorite sound?
My favorite sound. I'm a country girl. That shimmery sound in the summertime, where you can't tell if it's bugs or crickets, but it's kind of this. And it's always in the heat. So maybe that's because I live in Georgia, but kind of the shimmery sound in a hayfield. I know that's crazy.
No, I know what you're talking about. It's the wind going across the plants, right?
I love it. That's a great sound to me.
Yeah. So everybody, this is Dr. Alice Cellino. She's an audiologist and the executive director of Columbus Speech and Hearing Center, which is interesting. Not that you're going to, and I don't, but your name doesn't actually cover everything that you do, but that's a challenge. I don't know where you go to. It can't be like Columbus hearing, reading, occupational therapy, neuropsychology, physical therapy, vestibular evaluation, and hearing center. That's a little bit too much. But if people want to get a hold of you, how do they do that?
Yeah. So our website. I think my email is on our website, and so is our phone number. And please reach out, because I really do love what we do, and I love talking about it. So I'm very grateful. Thank you for having me on. But no, anybody call me. That's great.
No, this has been great. It's really interesting, and I admire your model, and your passion comes through. Sounds like your mom passed it on, and that's really wonderful. Your dedication to patients. So I really appreciate you sharing your story with us today.
Thank you.
Yep. Have a great day. Thanks.
Thanks so much.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.